I'm Brad, and this is Cancer Patient Lab. I'm just going to be on for a moment here, but I want to thank all the contributions. This running of a hackathon is a diverse crowd of people with diverse backgrounds, different expertise. But between Alvin and Marlo and the story, we've really caught fire. I'm really impressed with all the people that have contributed. There have been long email threads I've tried to capture and paste it onto our discussion hub, but there have been contributions so far from Ian Maurer, great stuff, Cal Moody, great stuff, Chris Opful, Alan Morris. I just want to single them out. They've all made excellent contributions to kind of figuring out what's next to do for Marlo. And with that, I'll turn it over to Alvin and Moody and Ari.
Yeah, no,
Sounds
just
good.
wanted to say I'm just really, really grateful here. I'm also here with Mom, so thank you so much for the contribution and support.
Thank you.
Hi,
Do we?
Alvin, and hi, Mom. Uh,
Jen.
Jen, hi, Jen, hi, both of you. Welcome here. And Ari, I'm gonna let you start, and then I'm gonna, as we discussed, I'm gonna lead in. Hopefully, we create some meaningful conversations that will help both of you
Yeah,
and little more. Yeah.
I'm
Yeah.
I'm not going to say a lot because I think we have a lot of um, experts that have been contributing on this, which is absolutely like amazing to pull such a diverse group of people around Alvin and Mo and Mom's case. What's Mom's name? I'm so sorry.
Jen.
Jen. Um, so really in spirit of helping a family with a 2-year-old going through something incredibly difficult. And so, really we're here to pull out the expertise and help you frame your next steps, what the right decisions are. There's obviously ambiguity, or else we wouldn't have so many people here. Maybe I could turn over just um, to you guys, to Alvin and Jen, on just where are we, where are you, just kind of anchor us on where we're at.
Yes, so again, yeah, just yeah, Marlo's been just going through a journey, yeah, going through chemotherapy, radiation, and just we're at a point where surgery for a four quarters amputation is not feasible. So we're just thinking, what are the next steps? And I think we've gone through this journey ever since birth, and we've learned a lot, lots of ups and downs. So I think that's where we're at a point where just wanting to leverage the community and really just kind of think through thoughtfully, because I feel like this is really important. Like we're playing like a game of maybe chess, or but every move is pretty key. So I think that's where I just wanted to leverage everyone.
Okay.
Perfect.
Thank
Kamudi, do
thank
you want
you,
to?
Alvin, for saying that. And I'm gonna jump in, and please absolutely feel free, Alvin and Jen, to kind of jump in where you feel like we've missed anything important. Okay.
Okay.
So I'm gonna share my screen, starting off with the Circle community page that we have all been on and have been contributing to. So let's look at this, right? Here we are, and here's our little Marlo. Everyone, let's just like bring ourselves to the same space. This is the little kid we're all, praying for, working for, and hoping to change, make a positive impact. So here, Alvin very amazingly has already kind of given us a background, right? Consider Mo Kwong, the 2-year-old son. He's a bright, curious little boy and we really need to kind of use our biology, medical skills, everything coming together. I mean, we have here medical doctors, we have here biologists, we have here community members and people with various different backgrounds coming to brainstorm in this hackathon. So most tumor shows some actionable biology so far, and I'm going to have some slides to go into this a little more detail, like we would in a scientific meeting or in molecular tumor boards to some extent. Okay, so there's actionable biology. I'm sorry, yeah, okay, including EGFR internal tandem duplication, okay, and other sort of markers. Now, as Alvin mentioned, Mo has gone through chemotherapy, radiation, and keeping in mind the age And the circumstances we kind of want to gear towards minimal toxicity, maximal effect. Like it's a cost benefit analysis that we're going to do together, all of us here, right? So I'm stopping sharing this because we all were familiar with that. And then I'm going to start with some slides I had prepared for today to kind of help us discuss. Okay, so let me just share my screen here. And all right, now we have this, and I'm just going to make it into a slideshow, which makes it easier. So, right, so Ari and I together put together this one graphic, looking at all the different streams of information and sources that we've had so far. Amazingly, for example, Ian, you provided that in-depth report that your company kind of produced, and Alan and other people that everyone here contributed to their best of abilities. So where are we at, right? So currently, Alvin and Jen are at UCLA, or at UCLA with Mo, not maybe physically there right now, but they're at UCLA, and they're trying to make a case actively to get a new biopsy sample so that a lot of the diagnostic testing we need to do can be done. And what are the key questions we have to discuss today? First of all, any tissue that's harvested, what is the best use of that tissue? Also, what other treatment paths should be on the table and what priorities should be placed on them? We can all brainstorm for these. So here, I've put forth a proposal based on my in-depth study of all of the information that came across. And I want people to kind of weigh in on this in this meeting, right? I think functional testing should be on top of the list on fresh tissue sample that can be obtained. But we need to decide which drug combinations or single monotherapies or etc. should be tested on that sample, because it's going to be limited sample. As we all know, sample is going to be bottleneck. So we have to test, we have to come up with eventually a list, one way or the other. I mean, we have experts on this team, and there are experts that Alvin has been also working with. WGS is in progress. Customized IHC panels should be run, and we'll discuss that. Okay. Getting ready for any sort of immunotherapy interventions, including expanded HLA testing, must be done. And then we'll talk about organoids also, as well as microenvironment profiling. In terms of treatment pathway options, we should talk about these ablation approaches like radiofrequency ablation, cryoablation, or histotripsy. Okay, back and forth, we can have a little bit of brainstorm based on people's expertise and knowledge about this. There was a very recent report that Alvin, I think, posted yesterday, which was a chemosensitivity type of testing that was already done. But then we can talk about the drug concentrations that were used in that testing, as well as what those results exactly mean. So there's this. And then there's information that has come up about HER2, CAR T therapy versus B7H3 guided treatments. So now, what do we all agree on so far? We all agree that precise diagnosis is foundational before immediate aggressive systemic treatment, because it's a tiny toddler we're talking about here, right? How big is that, system going to be? So what's the best use? I talked about this. Okay, Ian's report brought up this interesting trial, right? That was specifically aimed at undifferentiated sarcomas. It's a HER2 CAR T trial at Baylor. We should talk about biological and scientific thoughts on the bridging strategies using MEK inhibitors. And we should not only talk about the science behind it, but also the toxicity implications for a tiny little child using MEK inhibitors, okay? And we should also talk about, is this cancer still truly EGFR KDD driven? Do we have enough information to say yes or no? We should discuss that today, okay? It could be we just don't have enough information, but what are the pieces that are missing in that case? Okay. Now, if both antigens are expressed, if B7H3 CAR T and HER2 CAR T is a possibility, then are we the LLMs that are out there are telling us that if both antigens are expressed, then we should veer towards HER2 CAR T therapy secondary and place a higher priority on B7H3 CAR T. But is this really true? Do we agree? Is there enough information for us to make this kind of a claim? That's something else. And then I'm going to just quickly flip through a few slides, which are lots of words. We can keep that for offline, but I'm going to stop sharing. We will have a discussion as promised.
Can
So here
can
we
I can
are.
I chime in real quick, Comedy, if
Yeah,
we go back
sure.
one step,
Ab- Absolutely.
just one more maybe.
One more. Mm-hmm.
Uh, does everybody agree? Like Alvin, Jen, like this is all accurate and complete on what we agree?
Mm,
Um,
okay. Oh, I was just gonna mention, I don't know if radioligand was something to consider. I know Alvin's been looking into it
Yeah.
more, but I'm not sure if that's coming up or if that's something we should explore.
That's an excellent point, Jen. Thank you for bringing that in because I at least have not seen radioligand mentioned in our discussions so far, and it's definitely something we should talk about. So thank you for bringing that up.
Yeah.
what what is actually known right now about HER2 positivity? There's an ADC, like antibody drug conjugate against HER2. The Enhertu or trastuzumab deruxtecan. Do you know how positive Marlo is for HER2 right now?
I don't know off the top of my head.
The RNA-seq is pretty low in the one sample I looked at. I think it was 10 to 20 TPM. So I made a panel of all the ADC CAR T targets that didn't come up as particularly high relative to the other ones. But
Because the eligibility criterion on that trial is you have to be 2+ and like fish amplified in other indications. I mean, more common cancers. So would he hit a 2+, or is it more like a 1+?
And in the same vein, I don't think Alan Morris is on this call, but I
No,
would
he is.
love to understand.
He is.
You are? So Alan, would you, in terms of EGFR KDD driven, how can we have a better sense of how confident are we that this is the right target? And the same question to me applies to what do we know about the HER2 expression? How likely is targeting that effective? And is it possible perhaps even to combine both? And is it possible that cells do have, these are two different populations that have basically branched out, or are they on the same tumor? So Alan, do you have any thoughts on how to think about this?
Yeah, so you brought up you brought up HER2, and you also brought up the EGFR, and I could talk for 3 hours on it, and this is not the right venue. You know what? I have a hard time saying a few sentences, but I'll start with HER2. HER2 is probably one of the most studied molecules as far as actually in clinical medicine. And we all know it's been most studied in breast cancer. And trastuzumab, which is the antibody to it, has been used extensively. Everybody knows how to use it. They know there's cardiotoxicity. They know how to monitor it, all that. Okay, I guess that's too long because that's a tangent. Unbelievably, HER2 has translated into gastrointestinal. And it's not, that's another thing. When we talk about these things, we don't say what is established stuff that everybody knows about. Gastrointestinal, maybe it's already old. Maybe I'm dumb, and it's been around. I'm going to guess it's been around for 5 years as opposed to 20 years for breast cancer. It's in other cancers also. Obviously, it's not been studied in sarcoma. Just as a generic stupid statement, a lot of stuff hasn't been studied in sarcoma because it's rare. But going on to HER2, it's incredibly complicated from the pathology standpoint, and that is it's our output is 0, 1 plus, 2 plus, 3 plus. That is codified. Oh, well, then just do it on all cancers. What's the problem? You guys don't understand that when we say 3 plus for a breast cancer, that's not the same 3 plus as for gastrointestinal. In other words, pathologists had to figure out where the cut points are. And it's actually, I don't want to go into well, I will go into a quick nuance to show how complicated it is. It's not only a qualitative and quantitative assessment, and it's in the human brain, in the retina, and it's how strong the staining is on the membrane, what percent of the membrane is a complete membranous staining, and then how many cells and in what area. All already we have done a ton of permutations, yet the human brain is translated. Okay, what am I trying to say? I can
Absolutely, Ellen. So just to bring this home, that
yeah,
it's not an exact science. There's some art, if you will, to that entire entire endeavor.
yeah,
And
yeah,
so then again, bringing us back to our discussion, these are the now 5 points that we should talk about today. And just everyone remember that this is today's live event brings together a density of information in real time. But then as we built up to the event today, we kept sharing information. Please continue to share information after today as well, because based on what we speak today, you will have thoughts and afterthoughts, come up. Oh, maybe they could try this. Feel free to put that on the circle community that we've built. Okay. So now,
Kamini, can I just it looks like Grace has a question. Can we just jump over
absolutely.
to
Thank you,
capture that
Ari.
real quick?
Yes.
Hey, Grace.
Forgive me, I'm scarfing down lunch and breakfast, and I just want to share. So, just from experience on Cancer X. So, for those who don't know me, I'm a good friend of Brad's and have had the pleasure of participating in these in a while on a number of different patient cases in the past. My expertise is how can we leverage innovation, upcoming digital health tools and technologies to help give some information and intelligence to inform decision making. One successful platform that I've been using with many patients who are at this juncture in their care is First Ascent. I'm not sure, Alvin, if you and your family, I think you were able to connect with them. I'm not sure what your thoughts are, and if the team here that's orchestrated is aware of them. Essentially, it would require a biopsy sample, and they can test various combinations of drugs and therapies. The report gets turned around within about 10 days. They are a CLIA certified lab in Florida, and the reporting has been very thought-provoking and eye-opening. And I'm also wondering, is there a digital pathology option here, or an AI-powered analysis of available imaging that may help also inform treatment decisions? Not sure if that's already been done, but happy to connect to startups and companies that we have in our portfolio through Cancer X, which supported Biden Cancer Moonshot, if it's of any help or value.
Okay. Thanks, Grace. Yeah, we could take it offline. There's a few potential platforms and partners, but I think we could take that offline. Could be interesting.
I do
All right.
have values for HER2 expression. Hi everyone, I'm Long Do. I'm helping with most case. We actually got a hold of the sequencing, RNA sequencing. So the HER2 expression is 13 TPMs, which for sarcoma is actually pretty low. It's normal. So it's not out of the ordinary high. Okay, so just
Thank you. Thank you, Long, for sharing that important information. Yeah. All right. So I'm gonna share again now. And remember, the next slides are gonna be having a lot of words on them. We can go slowly in these, and I'll stop sharing and we can have the community have a discussion at points in that process as well. Okay. So here we are again. All right. So let me just scroll through. We did that. Now, this is where we're at. And this needs to be kind of confirmed here. So it looks like, oops, sorry. it looks like a complex karyotype was discovered more recently, where there is PTEN loss that was noted, RB1 loss, and MDM2 KRAS gains, okay, in the latest testing, which was not visible in the 2023 low-grade tumor. Is this accurate, Alvin and Jen, as per your knowledge thus far? Do you remember? I don't want to put you on the spot. We all have the records, but in case you do remember.
No, yeah, I just know, yeah, the high grade component of the tumor did show some
Did show up.
structural variants. So I think it, yeah, and they're related to a couple of the chromosomes. So
Chromosomes, yeah. Okay. Okay, so now given that, point number 5 here says EGFR ITD remains the driver, as was confirmed by St. Jude. My question is, when was this confirmed at St. Jude? Do you remember the date? Was it 2 years ago? Was it now, recently?
yeah,
Because
so
that's
yeah,
important.
so St. Jude, yeah, initially found it from the initial biopsy, the 2023 biopsy, and then I think CHLA confirmed they did see the EGFR ITD in the latest biopsy.
Excellent. Oh, excellent. So now we know that the latest biopsy has the EGFR ITD. It also has the MDM2 KRAS gain, the RB1 loss, the PTEN loss. Okay, all of these. Now, a question is, what's driving the tumor? One open biological question is, what is driving the tumor at this point in time? And do we have enough information to determine what is driving that tumor at this point in time? Okay. One point amongst these 7 that I also want to highlight now is that Alvin actually found this case of a 2-year-old in Valencia with a similar, EGFR KDD alteration, where afatinib started working after conventional therapies had failed. Now, this is most directly comparable to Marlo's situation in that sense of the EGFR KDD. However, this is only one example. It supports switching from erlotinib to afatinib. However, we know that Marlo has currently been responsive to the chemo plus radiation plus erlotinib combination. Okay, that's what we know thus far in the most recent, okay? These are 2 kind of points to consider. So now the question, if you look at point number 4 that I have here, is the question is, do we consolidate with CAR T now or explore other modalities? Or do we just say continue to successful regimen? And as we all know here, we are merely brainstorming. We are not Marlo's medical oncologist, but we are having a brainstorming session of multiple experts who have looked at all of the data available till date. Okay. And now, I mean, let's pause actually here. I'm going to stop sharing. And then I have a list of about now 17 compounds that we could talk about for chemosensitivity testing. And I just want to highlight chemosensitivity testing is done by Sage Medic. We have Dr. Chris Apfel on the phone, on the call here. It's done by First Ascent, as Grace Cordanovo kindly pointed out. And there are other companies, including Travera and other companies that also do this sort of chemosensitivity testing. Alvin and Jen had gotten one type of chemosensitivity testing, which they put the report in our documents that we've discussed thus far. So everyone should just be knowledgeable that there are multiple companies that exist in this space. And we're not going to go into the details of what each company does, because that's outside the scope of our time right now. And let each company talk to Alvin and Jen and let them decide. But just wanted to say that. So if anyone has anything to say about the 7 points I just presented, please go for it. The stage is open.
It might be worth flashing them up just so that we can reference them.
Sounds great. Thank you, Ari. Okay. All right, here they are.
Just another thought too. I know you mentioned the ifatinib. I think there's also osimertinib, or I think I'm mispronouncing it, but as a potential option as well. But I don't know what evidence there is to support him using it at this point.
Thank you, Jen. Absolutely well said. There are multiple inhibitors, and we should kind of talk a little bit about the pluses and minuses. Anyone wants to chime in what they bringing their expertise on this? We're not
I,
medical oncologists, but we're
I
just,
just
yeah.
I just wanted to ask a question because Alvin and I were talking the other day. Can you remind me, was it UCLA's recommendation? Like, what's the recommendation on the table right now? Was it the radiotherapy to see if there's a response to that to get to amputation? Can you just remind us, like, what is the sort of default right now move?
Yeah, so yeah, I think part of our strategy is just to switch to our new oncologist at UCLA. And that's where trying to just gather together, analyze the sequencing to then meet up with the oncologist who's seems to be more reasonable, more open-minded than our current oncologist. So I think that's the first step. And from there then as community highlighted, trying to get a biopsy, I think we've come upon some challenges. So new biopsy, and then the other point is once we're done with the standard of care, what do we do? Like, how much time do we have to bias towards what's next?
Right,
Yeah, so the
right.
current standard of care is doing the is chemotherapy. So that we have like a couple more rounds left of doxorubicin and ifosfamide, and then we're in discussion right now about doing additional radiation, which we would like. We're open to it, but if we can avoid it, considering the risk that it carries, you know. Yeah, that would be great, but it's
Yeah.
probably not likely we can avoid it.
Right, right. And so it sounds like just to put a finer point on the question, is UCLA, I seem to recall that there was a recommendation not to do an additional biopsy because of the sensitivity. I don't know, maybe it's a small target to collect it from. But is that an open question, or is it sort of resolved to go and get an additional biopsy, additional tissue to do some of the testing that maybe Kamudi and others are suggesting, or is that an open question?
So the current recommendation is from CHLA, and they are not open to doing a biopsy, at least at this time. They don't believe it would be safe for Marlo to undergo a procedure because he would have to go
Hmm.
under anesthesia, and of course, it's an invasive procedure. We have not spoken with IR in terms of like how safe that procedure would be, but currently his oncologist is not willing to do that. And even though we've
Hmm.
asked multiple times,
Yeah.
um,
We did talk to the ECSF Pete's oncologist, and it is at least from talking to her, like it is weighing the risks and benefits. I think is like at least on the table to consider. So I think just getting her perspective was good, and then hence switching to the new oncologist, I think we'll definitely be able to make more of a reasonable request.
I mean, uh, I think we're hopeful that a new oncologist would be more open to considering a biopsy,
Yeah.
so we can, do further testing.
I'd be
Oh,
curious from this
I
group.
have one question for both of you. I remember in some of our discussion threads, it came up about having some fresh tissue that was preserved appropriately from the past. So does such tissue exist theoretically on which, if in absence of any other source, there could be additional chemosensitivity testing done, first of all? And how old is that tissue? When was it collected? In 2023, 24, 25, that kind of a thing?
Yeah, so we were able to grow an organoid through the UCLA group, but that was all on the lower grade portion of the tumor. So it may not be representative, and I think it makes sense now going through the treatment to get additional biopsy, and that's where Yeah, we're hopeful. I think just yeah, we're trying to get set up a meeting with the new oncologist at UCLA soon to talk through those.
And to Grace's question in the chat, is there someone that is currently willing to perform the biopsy? Not to our knowledge. We did try to get a second opinion through insurance, but they denied that. So we're hoping to make that switch, and then also hoping that they would be more open to performing or, making a referral for a biopsy.
I have a quick
And just
question.
to kind of, oh, I'm sorry, I will just
Of
to
course,
recap, what kind of time frame are we looking at? What's the time window we have before the next treatment becomes critical? You just have to, what's,
Yeah, so he's
I think
let
that
me see.
yeah, one key is yeah, before doing more radiation, at least in my mind, I would like to be able to get a biopsy because then if we do radiation, then it kind of closes the window for us for some time.
Yeah,
so
so
when is it the next radiation or when is the radiation?
well, the next round of chemotherapy is on the 20th of this month. And then 3 weeks after that, we'll have another round, but I think just ifosfamide. And then 3 weeks after that, it'll be one last round of ifosfamide. And I'm not sure at what point we would be doing the radiation.
Thank you so much for sharing that. And there was a question, I'm sorry. Go ahead.
Sure. And pleasure meeting everyone. I was just wondering, I have to go, but I would love to actually carefully listen and review this case. And my heart is with both of you. And I feel that's amazing. You gathered all these amazing people to help. And I'm sure you guys gonna find a way to have your little one. If there is a possibility, how we can, I don't know where we can have access to the entire case. And also, if we have any suggestion, as you mentioned, we can actually do afterward. Just please share the link through emails at least, or if you can just dump it here, that would be amazing. I would like to make sure that I can contribute as much as I can.
Thank
Will
you.
do. Perfect. We'll figure that out offline, the sharing of the case details. So it sounds
Awesome.
like I think maybe even just starting at like a basic level, um, it sounds like Alvin, if I'm kind of hearing you right, you seem convinced to get the tissue based on the types of information that may be learned and the that it may influence the direction, radiation, continued chemo, and so forth. I'm just curious, like from this group, is that a decision that we should kind of harden? Is that like still an open question for you, Alvin, assuming that you can find somebody to actually perform the biopsy, or is it like you're still not sure based on pros, cons, what you'll actually learn from the interrogation of that tissue?
I think we're
And not
trying
to
to,
and not to put you on the spot, like for the group as well, if folks have thought about this.
yeah, I think, we would like to get tissue to do further testing. We are running into, roadblocks.
When
And
was when was the last, sorry for interrupting, when was the last biopsy? And perhaps I can help with organizing a biopsy. And then the question would also be then whether we should split the sample and get also sample to First Ascent. What I like about First Ascent is that they're also doing a full dose response curve. I think this is kind of a minimum requirement to get a sense of which drugs are likely to work. Um, so um, so we can take this offline. If it hasn't been, let's say, in the last 3 or 6 months, it should be able to justify a new biopsy, and likely also combine it with some genomics as well. We should actually think about those as well, in addition to the functional profiling.
yeah, our last biopsy was in October of 2025, so just a few months ago. There's also this question about whether or not a biopsy now would be helpful, because if his tumor continues to change, then anything we collect now wouldn't be as useful in the future. So there's also that I'm kind of like carrying in the back of my mind. But we do want to try to get additional tissue if we're able to. I know we had also talked with um, uh, another doctor previously who had mentioned that, even though his um, pathology report came back negative for the NTRK fusion gene, that sometimes those can be false. And I think Alvin had found something some literature about 21% of cases that were negative actually ended up being fusion positive. Anyway, so all I'm to say is like maybe that could be a new tissue could be helpful for reevaluating that for an FDA approved drug that could help save him as well.
How large is the tumor? Where would it be biopsied? Would it be a core needle biopsy? Would it be a surgical biopsy? Is it somewhere superficial where we can actually get easily to it, or how should I envision that?
Yeah, I think yeah, right now I think a PET CT scan might help to see after post-treatment to see where current activity is, but at least before they couldn't get into the mediastinum area, so they're able to get outside the chest wall for the needle biopsy before. But the first biopsy in early October was more behind the brachial plexus area, and that was a surgical biopsy, but that one didn't show the high-grade component.
So what the brachial plexus? I mean, that's up here, in the neck regions, going through the axilla. So
And then to the heart area. So I think they did posterior, at least I think from what I remembered for the surgical biopsy, but I think we might need to do a PET CT to see like where the I guess highest activity is.
do we have some idea how large the tumor is? Is it 1 centimeter, 2, 3 centimeters?
So like I think the last report MRI said it was greater than 5.
Yeah, it was like 5 point something centimeters in the biggest area. I think it's at least it's harder to measure, but at least that's what they saw like this.
Yeah, so we have a paper in the works where we actually also looked at different tumor locations. We know that from ovarian and other abdominal tumors, when there is local spread into the peritoneal space, the sensitivity resistance profile is basically the same. But once you start looking at hematogenic metastases, then some the metastases may no longer 100% correlate. So there is a kind of there's still a 50 to 75% correlation, but there are some cells that are resistant that would show up sensitivity in the other one. But of course, if you have only access to one, you would actually then say, okay, we can at least rule out those drugs that show resistance at that location. So it's still useful, but then also the question arises in your case, does it make sense to, if there are two different locations, is there any way we can get biopsies from both locations so that we can do both the genomic testing and the functional profiling from both locations and see where is the happy medium, where is the overlap that would make most sense?
Interesting. Yeah. I don't know if that would be feasible.
It depends on how large it is, right? Do we have an understanding now, since it says it's aggressive, is that since October or since when do we know it has morphed? And do we have any understanding of the tumor growth rate, the volume doubling time?
Yeah, I think the latest pathology did show like it's since birth it was in those areas start growing sometime after the July MRI scans of last year. The fastest growing is in the mediastinum area, but unfortunately they couldn't safely get into that area, so that's where the second fastest growing is outside the chest wall area, and then the third is still the brachial plexus area.
And do we know that the volume, let's say, has doubled within 3 months or something like that? Do we have some
Was
They
is
they
that
had the
like the
Ki-67 on
yeah.
the report, so I have to check. I think they said 17 mitotic rate per 10
Okay.
something, and then
Yeah. Okay.
yeah,
From
so
my recollection, the Ki-67 was pretty low. And someone else who's looked at it can catch me if I'm wrong in my understanding, but I think it was pretty low
Is that
from
for
what I'm.
the surgical biopsy or the needle biopsy?
I believe I'm talking about the surgical biopsy.
Oh,
So
okay. Okay.
yeah.
I think yeah, that area was like a lower activity area, so that makes sense. Yeah.
Is there any way we can easily monitor tumor response? I'm thinking of Signatera here, and I also recall that at some point Pete Kane and I we met at another cancer hacker meeting, and I think he one of his friends mentioned Personalis as well. So I'm actually asking myself, are there any liquid biopsies or informed liquid biopsy assays available that could be used? I mean, it would be certainly experimental and it would be an out-of-pocket pay. There's no question about this, but if this is metastatic, I would be surprised if it wouldn't show up in a Personalis or Signatera test.
Hmm. We did have I think a liquid biopsy performed with a sample of tissue that we had sent to Tempest. But I don't know if we have those results. Do we have?
Yeah, but there are liquid biopsies and liquid biopsy is not the same. It's kind of
Okay.
biopsy and biopsy. So that's a separate discussion. Well, it's probably of general interest. So what most commonly done tests on liquid biopsy, and Kaumudi, you know the space better than I do, and anybody else should probably chime in. But the way how I look at it, a liquid biopsy is basically a blood draw. There is on the very front end, there are companies like Grail that can do a pan-cancer screening test where you can actually screen, do you have cancer? And they're looking for something very, very different. Then if you are diagnosed, sometimes cancer DNA sheds into the bloodstream and certain mutations can be detected there. That's the most commonly application of liquid biopsies. That's during the diagnosis to identify what kind of mutations do we have, any target therapies. And then there is when the patient is receiving therapy, the quantifying the tumor burden and there are tumor informed and independent ones. And I do think that it's relatively clear that tumor informed are better. And the way how this works is they take a part of the solid tumor piece and sequence that and compare this with a normal tissue because we also have normal variations ourselves. And then those 15 or 20 mutations that are most relevant are then sequenced in much more deeply in the blood. And that's used to, that's Signatera's approach. And I do also believe it's maybe Personalis. And that's the approach to understand, is a tumor burden going up or is the tumor responding to the treatment? And most of the data suggests that it is more sensitive and more responsive than a PET CT. So that's one of the reasons why I was bringing this up. Kamudi, would you or anybody else any things to, or Emma? I see Emma is there as well. Would you like to? Is that a good way to frame it? Is that useful? Anything to add?
I first of all, I want to say that Ian's report is quite amazing, as many people wrote, because it's so comprehensive. I started communicating with Alvin in December, I believe, and my highest priority were trials with drugs targeting B7H3 simply because of the fact that it's most often expressed in sarcomas of various types. Unfortunately, very few companies do IHC testing. And even companies like Tempus or Boston Gene wouldn't even look for RNA for reasons that I failed to understand. So I think this is the most viable target currently, and Ian suggested some trials that overlapped with the ones that I suggested back in September. Of course, it's CAR-T. Success is not guaranteed, to put it mildly, but it's there. I would also support testing like what you do, Dr. Apfel, for sensitivity to various drugs, but I noted that some of the biopsies didn't produce many viable cells in the past. Correct, Alvin?
Yeah,
Yeah. So, but it's worth a try if it's at all possible. I really doubt that using any targeted drugs like MEK inhibitors under the circumstances will be of great benefit.
Thank you so much, Emma, for clearly stating your
HER2 is also a good target if it is present, which is a big if, but HER2 at least it's easy to stain for. A lot of commercial labs can do the IHC for HER2, unlike B7H3.
Okay, so thank you so much, Emma. And I'm going to now bring us to a slide that is capturing these points in real time that we're talking about right now. Okay, so let me just share this. Let's see.
May I
Yeah,
add a comment here?
absolutely.
I agree with Chris that, well, perhaps let me take a step back. I was texting that it would be important to know what is the mutation landscape of the tumor. So whole genome sequencing is I will say, the most comprehensive analysis that you can have in the tumor. And a tumor approach actually can help identifying what is the baseline, what is that fingerprinting. If you have like the original sample, that would be great because that's what is needed in order to do a tumor-informed MRT. And I will say from the technical perspective, any assay that is out there, whole genome sequencing, MRT, I think that is going to be able to detect those signs. Clinical validation, I think, is another important step. I was thinking that perhaps you want to take a look to OpenOncode. That's an open tool that is available. I can send the link. So they are showing data of all the different companies, the different tests, what tests are available for what type of cancer, which ones are validated. But I just wanted to add, I think that whole genome sequencing, again, cancer is a disease of the genome. And really evaluating the whole landscape of the whole genome is going to really reveal like all the biomarkers that are there. And that's going to be very helpful for not only therapy selection, but later on as well doing monitoring of the disease. I'm happy to
so much
offline, Alvin, but I just wanted to add this comment.
Absolutely. Thank you, Sandra. Thank you so much. And I'm going to bring us back to the first slide. So here we are again. Should we briefly talk about these? I'm asking this question to Alvin and Jen. Should we talk about histotripsy and RFA-CA as to have people chime in with their knowledge, opinion, take on any of these approaches? Because once we have that, we've kind of talked about HER2 CAR-T versus B7H3. Now, I see CGAT or other peptide-based vaccines as another approach, or RNA-based vaccines. We could talk about that a little bit. Should we talk about the ablation techniques?
I'm open to talking about those. Yeah.
Okay. Does anyone have any input on or weighing in on any of these ablation techniques?
Can we just jump to Jane just to make sure we get her question in?
So
Absolutely,
histotripsy
yes.
is an amazing technology and that has shown impressive results for liver metastases, for primary liver tumors and liver metastases. But because it's a ultrasonic approach and with basically a resonant frequency, it works well when you have somewhere where you have homogeneous tissue right there. It is harder when there is somewhere air. So if you are in the area of the thorax or other less homogeneous situations, it may be harder to apply there. And I would assume that so far, most of this technology has been really developed for liver, but I may be wrong. If we are talking about anything within the thoracic or other abdominal space, it might not work as well. So that's what I know about the histotripsy.
Thank you, Dr. Apfel. Anyone else who wants to chime in? Okay, then I'm going to move on
Hold on,
to
Jane's had her hand up.
okay. I'll stop sharing. Let's continue the discussion. All right.
I just want to go back a couple of steps. I know this is a very focused approach here, but I'm wondering, have we looked for, have we searched, have we asked for access to broader data sets on this particular type of cancer? So, for example, Tempus are very, very open and very collaborative in the rare cancer space. And there may be nuggets of information in their data sets. So, for example, they actually have collected tissue samples, they have deep genomic data, they've also got full EMRs as well. Are there things that we can learn from other patients' experiences? And also, most definitely, on some of this mutation data as well. It's such a rare disease that, I think we have to think about what other information is out there that we can use to either validate or even do discovery for your case as well. I think I know we're talking about this wonderful little boy today, but I think there's other data sets out there that we could potentially think about harnessing. And like I say, Tempus I've spoken to Tempus extensively about connecting with their cancer data sets, and they've been very open to those collaborations.
Thank you, Jane. That's an excellent point, to look in rare cancer data sets to see links other than the one case that was identified with the EGFR KDD, which is specifically most relevant to Mo. That's a point well taken. And I just wanted to rapid fire through some slides with lots of words to see if any of those jump out at any of you. Like, for example, Emma kindly shared that just the toxicity profile of the MEK inhibitors and all of that kind of makes her, and I agree, kind of less enthusiastic about using a bunch of MEK inhibitors combined on a small toddler such as Mo. But I'm going to just rapid fire here now because we have less time left. And then I'll stop sharing after that, and I'll share this offline for people who want to weigh in offline after this meeting. Okay, so let's go through this super quickly now. Let's see. All right, so if in an ideal world we have all the tissue we want, well, okay, no, let's not keep that factor. In a real situation, we have limited tissue, and we want to do chemosensitivity testing. Now, considering the patient age, these have been ordered and ranked a little bit, also considering what's known about pediatric cases and these various drugs. So my questions here are any drugs missing from this list? Any of the experts here, would you like to add something on this list? There are 17. There are 3 slides full of these, okay? Do you agree with the order? We don't have to go about that today. What dose ranges ideally should be tested for physiological significance? Because that's a key point that has come up already. And combinations, thoughts on monotherapy versus combinations, okay? So rapid fire. There's the PRMT5 inhibitor. MTAP loss has not been detected in the tissue, but usually MDM2 amplifications and MTAP loss goes hand in hand in at least adult sarcomas. Okay, so there's AMG 193. Then there's the MAT2A inhibitor, which induces methylation stress in MTAP deleted cells. Again, same axis. We could do chemosensitivity testing on an MDM2 inhibitor that reactivates wild-type P53 because that's found in pediatric tumors. Entrectinib, which goes after the NTRK, that axis, or which we earlier discussed that, even though it's not detected, it could be there hidden. Should there be a combination, which is going to the axis of P53 reactivation and the cell cycle arrest? Okay. Should we go after, let's see, should there be the EGFR inhibitors, a whole panel of EGFR inhibitors, including the erlotinib, which is currently working in combination with chemo and radiation, as well as the afatinib, which comes from that one case, as well as other EGFR inhibitors that are known. Okay. Doxorubicin, he's already receiving. Okay, and then these other ones that came up from the initial round of chemosensitivity testing on the, I believe it was the low grade tissue, but I'm not, don't quote me on that particular fact. Anyone wants to? Anyways, so the earlier testing that was done, looking at that report, everything was tested at 1 micromolar, which is so far away from physiological relevance, and it was only single dose, looks like. At least that's what was reported in the report. But so some of these came up, right? And then these we already discussed that maybe there's toxicities which would kind of make us put less weightage on these. And then finally, we already discussed HER2 and CAR-T. And I just wanted to show that, which I'll be sharing this list offline so people can add to it, subtract from it, poke holes in it, etc. And now the floor is open again for concluding discussion. And yeah.
If I may, Kamudi, you mentioned list of highly effective drugs. You just showed it. But why do you think they would be relevant in this case? Because MTAP loss would have been detected. Tempus was done, and for example, as well as NTRK translocation. So those are highly theoretical possibilities that are unlikely.
Absolutely. Absolutely. Excellent question, Emma. Thank you for poking that hole. And the reason I'm suggesting these for chemosensitivity testing is because if by the off chance that they were not detected, there's heterogeneity in the tumor, because it's such an unknown sort of an orphan case, the chemosensitivity testing would show us something that there's, some sort of activity here, which we didn't expect. And so even though none of that was detected, and yes, you're absolutely right, one would expect it should have been detected by now.
Yeah.
But then again, the first sample had only EGFR KDD, and then the next sample had all these chromosome losses, and we know the tumor is changing in real time. So it would be a good idea, I believe, to add these known sarcoma axes in any chemosensitivity testing panel. But this is completely open for debate.
Yeah, well, if it is indeed possible to retrieve enough cells for sensitivity testing, I think Dr. Apfel will be highly able to pinpoint the correct combinations of drugs to throw, because the numbers will be limited, and I would not prioritize targets such as
and sometimes it's actually difficult to know what is really active. I just pasted a graph into the figure of a young girl with I think it was an ependymoma, and there was an interest in looking at the CDK4/6 inhibitor ribociclib, which we tested, and it showed nothing on the cytotoxicity, but it actually showed very nice anti-proliferation. That's on the right graph if you look there. So the anti-proliferation is a green curve. And so sometimes, so cytotoxicity and anti-proliferation are two different pairs of shoes. And if you only are testing for cytotoxicity, you won't see it. Now, we also added abemaciclib to it, which is also a CDK4/6 inhibitor, and it actually showed cytotoxicity, and we were very, very surprised. And we then later found out that abemaciclib is actually less selective as ribociclib. And so ribociclib is really a pure CDK4/6 inhibitor, and apparently that tumor doesn't respond to the CDK4/6 inhibitors. But other CDK4/6 inhibitors, such as abemaciclib, has other off-target promiscuous effects and inhibits other pathways that one would normally intuitively not think of. And so that's the explanation why we see in abemaciclib, and it's known that it can actually have direct cytotoxic activities. And so that's actually one argument for why it's so important to really look at the tumor. And sometimes, even if you don't have that mutation, it could very well be that a targeted therapy could work because the targeted therapy would actually effectively target something else that we primarily would not be thinking of. That's a little bit yeah, an additional argument.
I'm looking at the time. We should probably I'm not sure who wants to hang and who wants not to hang. I'm happy to hang for a little bit longer. But just kind of officially to be cognizant of time, maybe we could wrap the official part of it with Alvin, Jen, like what questions do you have? There's, incredible amounts of jargon and, biomarkers and things flying around. But what are the questions in your mind that either you want to take offline and sort of get more clarity on, or any thoughts so far on the information presented?
Yeah, and I think there's just definitely lots of great, I think, synergy of folks trying to kind of piece together different things. So I'm just really glad, at least I see this as like a jumping off point. I think just trying to kind of take things a step at a time for each of the buckets. I'm thinking like if it's radiation, yes or no, tissue, and going through those in parallel. And I think then that's where next couple of weeks will be pretty important and critical as we maybe continue the discussion around those two big topics. And
I mean, I would also say, it seems like getting tissue is going to be the largest factor here for a lot of like what we were talking about today. And assuming, we aren't able to get that done at least or in a reasonable amount of time, or as I mean, reasonable in our terms, like what else can we be thinking of
Yeah,
in the meantime? I think there was a talk about like a liquid biopsy, looking at that. Blood draw is pretty easy. We've also talked about, well, very little, but maybe our interest in cryoablation, RFA. I don't know if biopsy is needed for those, but those seem to be potential routes, but I would be open to
mm,
learning more about it. We haven't really talked to many doctors about that specifically, so.
yeah. Okay, that makes a ton of sense. Maybe just to kind of frame up, at least the way I'm seeing it, you have a path which is you're able to find somebody to do the biopsy, you're able to get the tissue, and then there's, a set of questions from that, what type of tests, what targets, etc. There's a path where you don't actually get the biopsy, either you can't secure somebody to do it, it's not covered, which probably we should discuss anyway, like are there options if the payers are denying, or like there's probably a path there, like can you unlock that tissue biopsy? But let's say you don't, then there's a question of, okay, suppose we don't, what are the options that we should consider given that chemo or maybe radiation are being recommended as next steps? Maybe there's some liquid biopsy testing that you would do to kind of monitor the response, I suppose, and maybe they're doing that or maybe they aren't. But essentially, you need to know on that path what types of things should you be thinking about. Um, does that miss anything? Is there, and then there were like some other things I'm not sure how to put in there, like histotripsy, like does that fit into, I don't know how that fits or some of the other potential options, but is that like the simplest way to think about kind of your next steps here?
Yeah, I think simply, yeah, just like, one without tissue, one with tissue, and can we kind of go down both of those paths concurrently,
Yeah.
as we try to get a biopsy, what else can we be doing in the meantime? Like we really want to be as proactive as possible, um, in making all the right moves, as quickly as we
Yeah.
can.
And is
So thank
UCLA,
you.
is the switch,
Just in
uh,
wrapping, sorry, Ari, you
sorry,
did an excellent job of
I just wanted
capturing.
to ask on
Okay,
the
please
UCLA
go ahead.
thing, is that a
Mhm.
foregone thing that you're moving into UCLA, or is that an open question mark?
yeah, I mean, I started the process and trying to get an appointment sometime next week. So I think that's where yeah, we are transitioning over.
Yeah, it's our first time, so I'm not sure, how that process goes and or how long that officially takes, but hopefully it won't take too long.
Yeah.
Thank you.
Thank you. And so just kind of saying that, Ari, you did, I think, an excellent job of mapping it out. And so Ari and I together will update a map for you, Alvin and Jen, based on this meeting afterwards, which we will share with you. Adding the updated information that has been captured in this live meeting, and it's one of the outputs you'll get after this, among others.
Thank you.
Perfect. Really appreciate it.
I will